So it's my pleasure this morning to introduce Dr. Richard Lawton, who is part of the, as I said before, the well-known uh, member of the Lawton family. We have Joe Lawton, who's headed Ollie's medical series for about a decade now. And today we have one of his sons, an orthopedic surgeon. Dr. Richard Lawton grew up in Fullerton, went to um, uh, Colorado College where he played football and baseball. So he probably has firsthand knowledge of the kinds of injuries that he's now studied and has been able to repair. Interestingly, he has a PhD from DePaul University in industrial and organization psychology, and then he joined the family tradition by going to medical school at Emory University in Atlanta. Dr. Lockton did an orthopedic surgery residency at the Mayo Clinic in Rochester, New York, and has fellowships in Colorado. And while there, he served as the assistant team doctor for the Denver Broncos, which is, as you know, a football team. The Colorado Rockies, which I looked up, is a baseball team, and the U.S. ski team. And interestingly, these are some of the kinds of sports that he still enjoys and participates in. He currently practices in Durango, Colorado, and Moab, Utah, which is, I guess, not too far from Durango, um, and in South Dakota. Dr. Lawton is married and has three children, and he shared his interests, which include, to me, several risk-taking activities such as skiing, hockey, motorcycle riding, and flying. So it's good to be an orthopedic surgeon, so you have friends in the right places here when you, when you have hobbies like these. Okay, so today, the title of his presentation is Shoulder Pain, Causes and Treatments. Please welcome Dr. Richard Lawton and help me do that. Okay, Dr. Lawton, you're on.
Thanks, Joyce. That was really nice of you. And thanks to Russ, too, Dr. McKeon, for helping coordinate this. And thanks to my dad for sucking me into his vortex of educational misadventures. I'm proud to be a member of the Lawton family. My dad and brother Ted holding down the fort medically in Fullerton. They banished me further afield, so I'm in Durango these days. So we're going to talk today about shoulder pain. So naturally, in patients, family members, when they have a shoulder that hurts, they want to know why. That's very understandable. People want to understand what's abnormal going on inside of their body or their family member's body. Of course, what can be done about it? Pain is no fun to experience. They want it to go away. And how can we make it go away? Naturally, the big fear that patients have is they might need surgery to make the pain go away. But naturally, there are a lot of problems that occur in our body, including the shoulder, that don't require surgery to remedy. So patients and family members understandably want to know whether or not their problem is going to require surgery to remedy. They want to understand what will work in terms of fixing the pain, making it go away. Will physical therapy work? Will just time alone work? Will medicine work? Those are understandable questions coming from the patients and family members during these early discussions about the condition. And then naturally, they want to know what the recovery is from whatever condition is afflicting their shoulder. So we'll get into these topics today. We're going to sort of divide it up by category of shoulder pain, and we'll get into those issues on the subsequent slides. Anytime patients have pain, myself included, it generates anxiety. Patients certainly don't want to have a problem at all because it's an inconvenience. It can be scary, generate fear. There's always hope, naturally, that their pain will go away and it can be fixed. And because patients, we all just want to get better. I'm a patient myself. And so if you're a patient, you're having shoulder pain, and these are some of the emotions and thoughts you're having, that's totally normal. Everybody experiences that stuff when they're experiencing shoulder pain. So just in broad brush discussion to get the ball rolling, we're going to talk today about common causes of shoulder pain. Common things occur commonly. That's an adage in musculoskeletal medicine and medicine in general. We try to focus on the most likely causes of shoulder pain. The causes of pain in the shoulder are similar to the things that cause pain in other joints. Knee pain, hip pain, elbow pain, the things that can afflict those other joints can also afflict the shoulder similarly. Trauma or falls or wipeouts, car wrecks, those sorts of things can damage structures in and around the shoulder that generate pain. Wear and tear conditions, things like osteoarthritis, tendonitis, tears, we'll talk about those things as well. Very common causes of shoulder pain. Sports related causes of shoulder pain or activity related causes of shoulder pain. Those will also be addressed today. Things like infection and tumor, we're probably not going to spend too much time on those. Those can occur rarely in a shoulder or knee or hip or other part of the musculoskeletal system. But we're not going to talk too much about those today. I'm happy to entertain questions about those, especially when we're done talking about the other topics. So common things are common. Horses more common than zebras, even if they have clothing on. All right, so bony anatomy. We'll talk a little bit about the anatomy of the shoulder because it does lead to naturally discussions of what can go wrong in the shoulder and what can be done to fix the problem. So the bony anatomy of the shoulder, the shoulder is not quite a ball and socket joint like the hip. The hip has a ball with a socket that pretty much encircles the ball completely. And the shoulder is more of a golf ball on a tee where the ball is quite big with respect to the socket and the socket is quite shallow. And the ball in this case is the humerus. We'll have other photos showing this later. And the socket is formed by part of the shoulder blade. And this is an x-ray looking up at the armpit view of one's shoulder. And you can see down here where this is the T, that's the socket or the part of the shoulder blade that forms the socket that the ball or the part of the humerus, the upper arm bone, articulates on. So those are some of the bony components of the shoulder blade, and I rotated the golf ball and the tee to sort of show that a little bit better. The other parts of the anatomy naturally around the shoulder include tendons and muscles, including the rotator cuff. We'll talk about that in greater detail to come up later in the talk. The biceps, your biceps muscle becomes a tendon that attaches deep inside the shoulder. That's also part of the relevant shoulder anatomy. Pectoralis, or your chest muscle, that's shown on this illustration here. It starts on the chest and comes out across the shoulder. That technically is part of the shoulder joint by some definition, as is the triceps musculature in the back of the arm. And then in addition to the muscles and tendons, we have tissues such as cartilage, which coat the ball and socket of the joint. Labrum, we'll talk about that as well. Tissues called bursas, which tend to cover up tendons and help lubricate them. We'll talk about those things as well later in the talk. So if you've been told you've had a problem with the rotator cuff or the cartilage with arthritis or a tear in your labrum or bursitis, those are among the most common causes of shoulder pain. Those are going to be the things that we get into today. Just to discuss quite briefly some of the illustrations here. Here is a model of the bony aspects of the shoulder, including the humerus. That's our upper arm bone. It has this shaft-like portion at the top of which is the ball. Technically, the name of that is the humeral head. And that ball, again, articulates in the socket formed by this outer part of the shoulder blade. We call that that part, or the socket of the shoulder blade is called the glenoid. Here's the collarbone up in here. And if you were to fold the ball out of the socket, this is the cartilage of the ball. Here's the cartilage of the socket. Some of the structures here lining the socket, like the labrum and then the rotator cuff, sort of encasing all that. This is not how the shoulder looks in real life. You have to incise all the structure and dislocate the ball from the socket to get this view. All right, so I'm getting in a little bit too much detail. So get back to the causes of shoulder pain. Among the most common causes are trauma. You wipe out on your ATV into the mud pit like this poor fella. Those sorts of injuries can lead to fractures, dislocations where the ball dislocates out of the socket. We'll talk about those issues. Wear and tear. So people who do a lot of overhead lifting, shelf workers, grocery workers, iron workers, people who do a lot of overhead lifting for their occupation, carpentry, that sort of thing, they're at risk for developing wear and tear injuries to the shoulder. Um, Inflammation to tendons, inflammation to burses, tendon tearing, the development of arthritis, which is cartilage loss. We'll talk in greater detail about that. And then there are sports related injuries. This is a picture of Steve Carlton, a patient of mine who, when you do this, you can see how this very unnatural looking angle of rotation of the arm and the shoulder that can incur injury to tissues deep inside the shoulder. We'll talk about that stuff as well. Again, things we're not going to cover too much. Zebras. Remember our prior picture of the horse. Horses are more common than zebras, and we're not going to talk too much today about zebras. But we can discuss those sort of offline or after the talk if people are interested in such. Here's an x-ray of someone who has a terrible tumor affecting their upper humerus and their ball. It looks like a chondrosarcoma, extremely rare orthopedic condition that an orthopedic surgeon may see once in a 30-year career. So we're not going to talk too much about that stuff, even though technically they're the cause of some rare cases of shoulder pain. All right, so getting down to the nitty-gritty here, we'll start with the trauma and fractures. If you fall down either from a height like from a ladder, or you have some decreased bone density, even a fall from standing height can cause you to experience a fracture of around the shoulder. A fracture is the same thing as a break, which or the same, you broke your shoulder, you have a fracture or a crack. All those things are synonymous. Essentially what happens in these scenarios is when you experience a fall, the load that's going through the bone is greater than what it can tolerate and it breaks, just like breaking a stick or anything else you have around the home. If you put enough force through it, it's not bulletproof. It can and will fracture. Things like falls can cause the fracture naturally. We talked about that. And this illustration here shows different types of fracture. These are the things that orthopedic doctors talk about when they're sort of describing the types of fractures, because the type of the fracture depends or affects which treatment is best for that particular patient and that particular fracture. We'll talk a little bit about that on some of these subsequent slides. If you do experience, if you're unlucky enough to experience a fracture of your upper humerus or other bones around the shoulder, the recovery is about 2 to 4 months, which is typical for most fractures. If you break your femur, you break your hip, you break your finger, those bones melt back together, but it takes a good 2 to 4 months for that process to finalize and get you back in the game. The surgery, is surgery needed for fractures? It may or may not be. The pendulum on that, the needle on that is slid back and forth. We'll discuss that in greater detail in some subsequent slides. So here's a little more detail about fractures. When you fracture your shoulder, there are several bones in and around the shoulder, as we mentioned before, including the humerus shown on this x-ray. And this fracture extends right through here, and then the ball is sort of busted up into 3 or 4 additional pieces. It's quite a bad fracture. So you can fracture the humerus to be sure, and you can also fracture the socket. Here is a illustration of a shoulder where the ball is normal. You see this sort of crescentic shaped line extending through the socket, indicating a fracture of the socket. That's called a glenoid fracture. You can also fracture the scapula well over here. Naturally, you can fracture your clavicle, your collarbone. And there's, as we showed on the last slide, there's a range of complexity. They can be quite simple fractures, or they can be quite severe. So we'll spend a little time talking about that as we move forward. If you have a little crack through your humerus here, where there's a little line extending on this x-ray right through here, maybe one coming through here, but the parts are not blown apart, it's more of a crack, definitely a fracture. The bone is broken to be sure, but the parts aren't blown way apart. We call that minimally displaced. The parts are not pushed too far apart from one another. And typically the treatment for that is non-surgical. The pendulum has really swung toward non-surgical treatment of these over the last 15 to 20 years. It used to be that just about any amount of displacement, including that demonstrated on this x-ray, would lead us to recommend surgery. But we've learned through well-designed studies that the patients who have an injury like this, a minimally displaced fracture, the parts are right next to where they were before they broke. They do just as well if you treat them without surgery as you do with surgery. So why incur the risks of surgery in that patient? they're going to do equally well without surgery. So let's treat them non-surgically. And that means usually, I'm sorry, I'll get into a couple more details. You can suspect that you may have a fracture of your shoulder if you've had a fall and you experience pain. And the treatment for these, again, is most typically non-surgical means, including placing the patient in a sling, uh, adding a little physical therapy when they get to be about 3 or 4 weeks out from the fracture actually occurring. At that point, 3 or 4 weeks out, the fracture isn't healed, but there's some good early healing to permit initiation of physical therapy, which can last another 6 to 8 weeks thereafter. For total recovery from this sort of injury is a good 6 to 10 weeks before the shoulder is functioning reasonably well, another month or two before it might be considered normal by the patient. Again, we categorize these into displaced or non-displaced, and when the parts are separated, that usually implies the patient had a higher energy injury, not necessarily a fall from a standing height, for example, maybe a bad car wreck or a fall from a ladder, fall off the roof. Those can cause the fracture parts to be pushed more further apart. Non-surgical treatment for these is often not recommended, because if the anatomy is badly distorted by the fracture and the parts are blown apart, they don't magically sort of come back into their normal alignment. And if they don't, then if they're out of shape and the other tissues around the shoulder are damaged, then the subsequent function, if you just leave things heal, is going to be poor, or more likely to be poor than if you're able to reorient everything. So operative or surgical treatment options include reassembling the pieces, literally putting the jigsaw back together, fixing those pieces in place with a variety of techniques, including using a plate and screws. If the parts are really badly damaged, including the ball itself, which is fragmented into multiple pieces, sometimes a shoulder replacement is recommended for those if the fracture is really quite bad. And so here, you might remember this x-ray, we showed it earlier in the talk. We have a bad fracture going through this part of the humerus, the ball right here, also these tuberosity, these little bony knobs have been displaced. And if you have a surgery, you can reassemble those. Now, this might look like a very disturbing x-ray, I can understand that. But if you look at the shape of the bone here, it looks pretty normal. So the surgeon who did this surgery, wasn't me, I got this picture off the internet, was able to jigsaw those parts back together. And they inserted a plate that goes down this side of the humerus and screws that fix this main part of the fracture to the ball and the other components. So that's a good looking x-ray. Whoever that patient, if that fracture heals, which it should, will have a normal or nearly normal shoulder once it's all said and done. The healing for that is a little longer, maybe 3 to 5 months total. So a little bit of a summary about the shoulder fractures. You have a little crack, the prognosis is excellent. So if your fracture looks like this illustration up here, where the fracture sort of comes down through here, maybe even across there, but the parts are not displaced from one another, those patients typically do very well, because once the bones heal, it's as though the fracture never occurred at all. The anatomy is pretty normal. The results or prognosis if the fractures are displaced apart, and that requires a surgery to either reassemble and fix those with plate and screws, or treat it non-surgically, or with a shoulder replacement. The results are good, but they're less likely to be considered normal by the patient once recovery is complete. The more displaced and the more severe the fracture, the blood supply can be disrupted to the ball, and that can necessitate additional surgery, can be associated with poor motion, weakness of the shoulder. So we worry a little bit more about a patient with this fracture than with this fracture. Even though a lot of these patients do well, the chance of doing well is a little bit lower than if they have a fracture like this. Fracture of the socket or the shoulder blade, the glenoid as we call it, the decision about whether that patient should have surgery or not is driven by, again, how far apart the fracture fragments are displaced from one another. And this amount of displacement is pretty typical for a glenoid fracture. If it's minimally displaced like this, the parts are really quite close to one another, then usually we recommend no surgery for that. Those usually heal quite well. And if it's really severely displaced, which is quite rare, then surgery can be recommended for that. Non-surgical care, usually things like physical therapy are recommended. pendulum swinging, physical therapy, sling wear, that sort of thing. Again, the total recovery from that sort of fracture is a good 6 to 10 weeks. So shoulder dislocation. Shoulder dislocation is when the ball dislocates out of the socket. Here's the socket way back here, and normally the ball should be riding back here in the socket. But in the case of a shoulder dislocation, the ball displaces usually towards the front. You can see the rib cage over here. That this illustration represents an anterior shoulder dislocation where the ball comes out the front. It can also dislocate out the back. Shoulder dislocation is different than a shoulder separation. Dislocation is an entity affecting the ball and socket part of the shoulder joint, and a separation is when the collarbone or the clavicle separates from this part of the shoulder blade. And so we're going to talk now about shoulder dislocations. The shoulder, because it's not quite a ball and socket, it's a ball on a relatively flat surface like a golf ball on a tee. It's less stable than other joints, and there are a couple reasons for that. It's less of a socket, more of a plate. The common causes of shoulder dislocation include primarily traumas and falls. There are very rare exceptions to that, but it'd be very rare for someone to have a shoulder dislocation without a trauma, such as a fall. This Santa, if you didn't get what you wanted for Christmas this year, it's because Santa wiped out on the way to your house. The symptoms of shoulder dislocation include noticeable visible deformity. You can imagine if your ball is dislocated out the front, you look down, it's going to look weird. It is definitely an obvious deformity for patients who are able to get a look at their own shoulder. They're unable to move their arm. It's extremely painful. Imaging, if you were to get an x-ray, when I say imaging, I'm sorry, what I mean is x-ray or CAT scan or MRI. It's going to show the abnormality quite clearly in almost every case. And the treatment for that is to simply pop it back into place. Typically that can be done in the emergency room, sometimes even in the field. If we can get to someone immediately after their dislocation on the ski hill or on the football field, we can get the ball back in the socket on the sideline, often have the patient even do that themselves. There are a couple tips and tricks that we've learned over time to help get that problem resolved quite quickly. Very rarely does a shoulder dislocation ever need a surgery. I can't think of a single case I've ever encountered that I've had to do that. I know those cases do exist. It doesn't mean that I'm good at non-surgical treatment, but if you have an unusual dislocation, which tendons get torn and pop down between the ball and the socket, those tissues cannot be pushed out of the way unless that patient goes to the OR and they're physically pulled out of the way, and then the ball will go back in the socket. But I'd say 99% of the time, the treatment for shoulder dislocation, especially first-time dislocation, is non-surgical. Usually after non-surgical treatment, you pop the ball back in the socket. That patient has a period of rest of several weeks, then initiation of some physical therapy, and typically that's all it takes. Those patients typically do well. Now, if, on the other hand, the patient experiences multiple dislocations, their first injury occurs when they have a bad fall skiing, and then the tissues that are torn, the labrum in particular that helps stabilize the shoulder, when one has a dislocation, those tissues can tear. And just because the ball gets popped back in right away doesn't mean that those tissues that stabilize the shoulder heal well. Those tissues can remain torn, and that renders the shoulder a little bit more unstable than it was prior to the first dislocation and predisposes the shoulder to have subsequent dislocations with lesser traumas. So once a patient has their first dislocation, it can start coming out when they put their coat on, or when they sleep at night, or when they reach back to get their seatbelt on. And when that sort of entity exists, when you have the tear of the labrum right here, that can render the shoulder suitably unstable, such that it will not heal well on its own, and a surgery is required to repair that, in which you put these little suture combination structures in there. Those are called suture anchors, to repair that torn tissue, tighten up the shoulder a bit. And the surgery for that is usually all arthroscopic and typically successful. More often to be required in young adults, especially males, for some reason. Recovery from that surgery is about 3 to 6 months, and the results are quite good. But again, the vast majority of patients who experience a dislocation will have just one dislocation, never need surgery. All right, any questions about shoulder dislocations, Joyce? Any other questions popping up?
Oh yeah, Pete Smith has a question. Pete, you want
What
to unmute
what
yourself?
about ligaments being torn? Is that what's the treatment for that?
In the case of shoulder dislocations, this sort of represents the ligament that's torn, the labrum, and then the other ligaments, the anterior or superior, middle, and inferior glenohumeral ligaments are tissues that are adjacent to and sort of converge into the labrum. And this picture here illustrates not only repair of the labrum here, which is a ligament-like structure, but also sort of oversewing of the ligaments immediately adjacent to that. A ligament repair is part and parcel of a stabilization procedure of the shoulder. Does that make sense?
Yeah, I'm just wondering if it's changed. I had a bicycle accident and they put a plastic strip. There were some ligaments that were torn, and maybe it was to help them grow back together. But
Mm-hmm.
I don't know if there's plastic strip in there anymore.
There's the type of material that these structures, these devices are made. They can be metal, they can be plastic.
Okay.
Can have these little, I don't know if the color shows up, but these blue or black looking things. Those are sutures that are made of sometimes absorbable, sometimes non-absorbable suture material. You can use Dacron strips. That's an older school technique, but that has been described. So when it comes to repairing an unstable shoulder that's dislocated, there are multiple different techniques using all sorts of devices, but the main component that's shared among all the repairs includes getting the ligaments in the labrum sewn back with a little tightening to stabilize things a little further. All right, so now we'll get to a topic of great interest because it's a very common condition. That's problems with the rotator cuff. Rotator cuff is among the most common causes of shoulder pain for the patients walking in, especially patients over the age of 40. When they come in and they say their shoulder hurts, this is usually at the top of the list and are on the usual suspects. The rotator cuff, it's sort of hard to understand what it is, but I'll try to explain that here. Rotator cuff is a collection of four muscles that start on the shoulder blade. There's the shoulder blade covered up with three of the rotator cuff muscles. The fourth is on the other side. And they start here as muscles, and as they extend out towards the humerus, toward the this part of the shoulder, they change from muscle, which is shown here as sort of red tissue, into tendon, which is shown as white. And the tendon's job is to attach the muscle to the bone. That's normal. So these start as individual or discrete structures, and as they get out here, they sort of converge into a single cuff or sheath of tissue that attaches to the humerus from the back all the way around the front. Here's a view from the front. This shows the one rotator cuff muscle here in the front called the subscapularis, and about here it turns into a tendon that fastens to this part of the humerus. This is the most commonly torn one called the supraspinatus up here, where it's muscle turning into tendon and attaching to this little bony crest right there. This same muscle, the supraspinatus, when you look, is shown here from the front, and if you look at the shoulder from the back, that's the supraspinatus here. So it's a little confusing, but essentially it's a group of muscles converting into one sheet or common cuff of tissue that attaches to the upper humerus. And they help, those muscles and tendons help keep the ball in the socket and control it, while the bigger muscles like the deltoid, pectoralis, those bigger muscles are the main ones doing the lifting. And while those bigger muscles are doing the lifting and the greater motion, the rotator cuff is helping to keep the ball within the socket and provide accessory control of the shoulder. So among the most common causes of pain around or including the rotator cuff are those associated with inflammation. And now inflammation is a normal response to injury. When we overuse our shoulder, we fall on it, the tissue can be injured at sort of a microscopic level. without experiencing a complete tear or a fracture. And when it's injured, thusly, its normal response is to develop inflammation. Um, it can occur with overuse, as I mentioned, trauma. Now, inflammation is a normal process because it's the first step in tissue healing. Anytime we have an injury to our body, we break a bone, we have a heart attack, we have overuse to our shoulder, and there's little injury to those tissues. The first component of healing, the first phase of healing, is inflammation, because that brings in chemicals and cells that are required for the tissue to repair. Uh, those chemicals not only lead to healing and repair, but they cause irritation of the tissue to protect you from using it, and that generates pain. Now, if inflammation extends longer than it should, then we have a problem that's not going to go away on its own. Shoulder pain, in this case, will persist, and treatment is often pursued. The tissues about the shoulder, which are most commonly affected by inflammation, include the bursa. The subacromial bursa, is a gelatinous, filmy tissue that overlies the rotator cuff. Its exact purpose doesn't seem to be clear, but we do have bursas around other joints, around our elbow, our wrists, ankles, hips, and those tissues, the bursas, seem to overlie tendons that go around the corner of bones. So here we have a corner of our shoulder, the tendon goes around that corner, there's a bursa overlying it. We think the bursa's job is to help protect and lubricate the tendon a bit, and that bursa can be pathologically inflamed and stay inflamed for a long time. If it becomes inflamed, it can become thickened and painful. Symptoms of bursitis include pain with motion. Lift your arm up or you twist your arm. It can cause a pinching pain in your shoulder that sometimes can even persist at night without any motion. Usually, if you were to get an x-ray of somebody who had bursitis, even an MRI, oftentimes a bursa looks pretty normal. And so while imaging is something that we use commonly, it doesn't necessarily, if it's normal, it doesn't necessarily mean that you don't have something wrong with your shoulder. Bursitis may well be the cause. The treatment for bursitis is usually non-surgical, and the good news is usually non-surgical treatment is quite successful in treating bursitis inflammation about the shoulder. Surgery is rarely needed for this condition. If you have bursitis, I would recommend that you undergo a period of non-surgical treatment of at least a couple, 3 months. And if it persists after that, you might be somebody who needs surgery to make that pain go away. Certainly okay to live with bursitis. It's not going to kill you if you want to just live with it, especially if it's mild. This image down here naturally shows an injection. One of the hallmark treatments for chronic bursitis that's not responding to things like medications is a cortisone injection. You can have a single injection cure that problem. Those patients walk out of the office quite happy, and you don't usually see them back. Very successful for chronic bursitis. Another form of shoulder inflammation is something called a frozen shoulder, what we refer to technically as a condition called adhesive capsulitis. That's different than bursitis. It's similar in that there is indeed inflammation, but instead of the bursa being inflamed in bursitis, when it comes to frozen shoulder, it's the joint lining that's inflamed, capsule. So these images show, if you were to strip away all the tissues around the shoulder, the muscles and the rotator cuff tendons, what you're left with is the shoulder capsule. The capsule is what contains the ligaments and also what keeps the joint fluid, or essentially what is like motor oil, inside the ball and socket joint of the shoulder. And it's that joint fluid that provides the lubrication to have nice, smooth, pain-free motion. And in the condition of a frozen shoulder, it's the inside of this tissue that becomes profoundly inflamed. And this illustration makes essentially this one, but everything's colored red. And that's what adhesive capsulitis. The causes are a bit unclear. About 50% of the cases we'll never understand why it develops. It just occurs unluckily in some patients. But there are risk factors. If you have a surgery or an injury, even one treated without surgery, that can cause you to develop adhesive capsulitis or a frozen shoulder. Diabetics, for some reason, have a higher risk of contracting a frozen shoulder. But by far and away, the most common cause, greater than 50% of patients who have frozen shoulder will have none of these risk factors, will have never had an injury, don't have diabetes. Their shoulder just starts to hurt for no good reason, and they have the other hallmark signs and symptoms, physical exam, and other findings consistent with a frozen shoulder. Symptoms like this, symptoms of adhesive capsulitis or frozen shoulder, like many shoulder conditions, include pain, especially pain with motion. Pain at night is another hallmark symptom of frozen shoulder. And most typically is a loss of motion in all planes. That is, patients find when they try to lift up their arm, it simply won't go any further than this because the capsule is tethering it and not permitting it to move. Rotating the arm out to the side or up behind their back, likewise, are those motion planes are limited by leathery, painful endpoints. The treatment for frozen shoulder usually, again, is successful with non-operative means. This is a demonstration of someone doing the pendulum exercises or elephant trunk exercises where they lean over. The affected arm is just sort of swirled around like a pendulum or an elephant's trunk. Other physical therapy stretches are usually part and parcel of the successful treatment. Even if you treat it with time alone, the average course of time that this condition exists is about 6 months. That's average. It certainly can be shorter than that and longer than that. But even if you do nothing, usually this condition resolves on its own. Physical therapy can be helpful. Medications, over-the-counter medications such as the anti-inflammatory medications, those would be medicines like ibuprofen or Aleve. If you're okay to take that, if you don't have any problems with ulcers or kidneys or other medicines that your other physicians are worried about, then anti-inflammatory medications are considered a hallmark component of the treatment of the frozen shoulder. Cortisone injection is the best bang for the buck in the treatment of this condition. You have to be a little careful in diabetics because a cortisone injection can disrupt their blood sugar control. So you want to make sure if you're considering cortisone injection in a diabetic patient, you've got the cooperation of the patient's primary physician that can help you monitor and carefully control their blood sugar after the cortisone shot, but quite effective in terms of curing the condition or at least shortening its course. The last time I did surgery on someone with a frozen shoulder, I think it was about 8 or 10 years ago. So it's a common condition we see a lot in the office. And if I'm only doing one surgery over 8 or 10 years, that means the vast majority of patients never need surgery. That vast majority of patients do exceptionally well. Their condition resolves completely with non-operative treatment. Now, the rotator cuff itself can be damaged. The reason for that is the blood supply to the rotator cuff is marginal. Here are a couple of illustrations demonstrating a rotator cuff tear. Here's one of the muscles coming on out, the one in the front called the subscapularis, that's attaching to the bone normally. But it's this one on top, the supraspinatus, that's coming out, and there's a tear extending right through it, right adjacent to where it attaches to the bone. This is a very common tear type. Here's another illustration of essentially the same thing, where the supraspinatus tendon here used to be attached to the bone over here. It, for some reason, has torn from here and retracted back like a window shade. The reason for that is the blood supply to this part of the tendon is marginal, and over time it tends to get poor, and eventually the straw that breaks the camel's back is when that patient lifts something up that they've done a millionth time, or they have a slight fall, or some other relatively minor trauma. That tendon that's been growing weaker and weaker over time because of its marginal blood supply finally gives way and retracts a bit. We know the tendon weakens with age. Again, the mechanism is more likely just one of attrition, where the tendon tends to weaken over time and tear eventually. The tear can start small. Maybe this tear at one point was a tear like this, where the tendon is torn completely, but it's not pulled back far. But over time, the tendon can retract and pull further and further away from the bone to which it was originally attached. It happens about 40 to 50% of the time. If it gets too big, if the tendon pulls way back, this is getting to the limit of what we can fix, it can become unfixable. That is, if you can get to this tendon right away, within a few months, you can sew it back to the bone and the patient will have a normal shoulder in the end. If you let that tendon tear linger for a while, about 50% of those tears will enlarge and get to the point where they're too big for us to grab onto that tendon, pull it back over the bone. The stretchability or elasticity of that tendon will go away over time, and the tendon will tear and denature and won't even be able to hold the suture at all. So that is what we call an unfixable cuff tendon. That's a real problem for patients who are unlucky enough to develop that condition. We'll talk more about what to do for those. So rotator cuff tears, usually patients, again, don't recall a trauma. They get confused when you tell them, when the doctor tells them, hey, you have a rotator cuff tear, they say, I don't believe you because I didn't have a fall. I didn't trip on anything. I don't have any history of any significant injury. How can I have a tear? And that's quite common. Is for most patients who have a rotator cuff tear, have no history of a trauma. Pain seems to begin sort of out of the blue. There's sometimes often painful popping or snapping up around in the shoulder. Patients comment about, point at the shoulder. The pain is certainly worse when they're using it, especially with their elbow out away from their side. This sort of thing, especially with resistance, picking up heavy objects, can make the pain worse. Pain at night, especially when they're sleeping on the affected shoulder. Some patients will report a sense of weakness in the shoulder. The diagnosis of rotator cuff tear, usually once we hear that sort of history from the patient, there are a couple things that we can do on physical exam to help us cone down on things. If we detect weakness with a couple special rotator cuff tests, with that increases our suspicion that a rotator cuff tear may be present. Typically, an X-ray that just shows the bone are normal because the rotator cuff is a tendon, has no bone in it, so it doesn't show up on an X-ray, even if it's badly torn. So if you have an X-ray of your shoulder and it looks normal, that doesn't mean that there's nothing wrong with the shoulder. It just means there's nothing wrong with the bone. Usually the MRI, this picture here is from an MRI of a shoulder. It shows the tear quite clearly in this case. I'll point out what that means here. The radiologist put a little arrow in here. That's always helpful. But this is the edge of the tendon. This is the supraspinatus tendon. And normally this bit of tendon is attached to the bone way over here. This bit of the tendon normally is attached to the bone over here. So what's happened in this case is that tendon is torn from the bone and retracted again like a window shade, sort of like what we saw up in this picture here. So if you look at this shoulder from the front where the tendon is torn and pulled away from the bone, if we go back to this MRI image, that's the MRI image of that very much same type of cuff tear. The treatment, non-surgical treatment, especially if the patient isn't having much pain, if they're relatively low demand, if they're medically unwell, then I think non-surgical treatment is definitely worth considering. And non-surgical treatment in this scenario consists of resting the patient, having avoid activities that elicit their shoulder pain. PT stands for physical therapy. And so you can work with these stretchy cords, work with a therapist to have you work on strengthening and trying to get other tissues in the shoulder to compensate for the torn tendon. Injection of the shoulder usually doesn't make the tendon heal. It can make the shoulder feel a little better for 6 to 8 weeks. The injection typically wears off. The tendon is still torn at that time. So injection isn't really curative in this case as it is in other diagnoses. It's an option though. Non-surgical treatment is worth considering if the tear is partial, if the patient is again of low demand. These things, none of these treatments, rest, therapy, injection, will cause the tissue, the torn tissue, to heal. So they're typically not curative. What we're trying to do, we have limited expectations when we initiate non-surgical treatment for, especially for the sorts of tears that we showed on the MRI images prior. We're just trying to help with the pain. And if we can decrease the pain and get to the patient who certainly, if they do not want surgery, if they understand the ramifications of that, then we'll do our best to help them with non-surgical treatment. Surgical treatment is usually recommended for patients who have persistent pain, who have a significant tear that's fixable. In those cases, we can get that patient's shoulder to become normal by sewing the tendon back to the bone. And there are all sorts of different techniques by putting suture through bone and through the tendon, tying knots, and that brings the tendon back to the bone where it will heal. You've recreated normalcy to that tendon and that shoulder joint. And those patients usually in the end are quite happy. The recovery from that is not short, it's not fun, but if in the end it produces a shoulder that's normal, most patients in the end they raise their hand and say, yes, I'm glad I had that done. My shoulder now is normal, whereas before the surgery it was terribly painful and I couldn't do what I needed to do. I had a hard time sleeping. Now my shoulder is normal. I'm glad I had that surgery done. Most patients end up in this condition. There are very rare exceptions to that. Trimming the tendon without repairing it, that's considered a salvage option. The results of that are not great. If the tear is too big for us to fix, before I showed an image where the tendon had retracted all the way back here, if that tissue quality is so poor that you can't fix it, it won't hold a suture, or you try to pull it over to the bone and it simply won't come because its elasticity is gone, and you just want to try to trim that tissue up, that's an okay option. Not a lot of those patients are happy in the end with their result because their tendon is still torn. The function and the mechanics of the shoulder are still abnormal. So trimming, while it's worth discussing, I'm not sure is a great option for many folks. Shoulder replacement, we'll talk about that. If the tear is too big to repair, those patients, and if they have bad pain, often choose to have a shoulder replacement. We'll talk a bit about that further in the talk. All right, so that's the end of the discussion of rotator cuff tears.
Okay, good. There are a couple of questions that were in chat, including one of mine, so that I wouldn't forget. Question about bursitis. Other than PT and cortisone injections, what are some of the other non-operative treatments for bursitis?
So medicines, things over-the-counter, Tylenol, ibuprofen, anti-inflammatory. Some people are big believers in some of the supplements, things like glucosamine, chondroitin, turmeric, garlic. I've had patients feel quite convinced that those supplements help them with their bursitis-like pain. Some people choose to do massage or chiropractic care. The results of that are more equivocal or not well founded in well-designed, controlled studies. Those would be the main things, aside from, and I'm sorry if I did not mention physical therapy. That's part and parcel of non-surgical treatment of bursitis as well. So medications, therapy, time alone, alternative remedies, whether that's supplements, acupuncture. Some people are big believers in it. I had acupuncture on my knee once. It made me a believer. We're not sure how it works, but can it be effective for cases of inflammation? Definitely no harm in trying that. And then cortisone, those would be the main non-surgical options.
Okay. One more thing in chat. What tissues are the adhesions in the frozen shoulder?
The tissues affected are those of the joint capsule. So the synovial tissue that lines the inside of that tissue that we showed on that one illustration. And all of our joints, our fingers, wrists, knees, shoulders, have a capsule that keeps the joint fluid in. It's a leathery tissue. It's a few millimeters thick, but quite strong. And for some reason, in patients who have adhesive capsulitis, that's the tissue that's inflamed, and its elasticity is adversely affected.
So Pete Smith had a question. You want to unmute yourself and ask your question, Pete?
Yes. As you talked about options for treatment, what would you use to decide whether to go to a pain management doctor for, say, a sore shoulder versus an orthopedic doctor?
I would recommend seeing, I'm biased, of course, I'd recommend seeing an orthopedist, or even a good family medicine doctor would be sufficient. What you need first is a good diagnosis. And if you go to a pain management doctor first, I'm not sure that they would be as apt at getting to your diagnosis and getting appropriate treatment undertaken. That is, there's some conditions in the shoulder for which pain management is perfectly fine, but there are other conditions, specifically rotator cuff tears we just went through. If you have a rotator cuff tear and you engage in a year or two of non-operative treatment, and you don't know that you have a rotator cuff tear, you can miss the boat. That water under the bridge, if the tear is getting bigger over that year or two non-operative treatment and you're not aware of it, and then all of a sudden 2 years down the road, the pain management doc he's not been able to cure your pain, and at that point you get an MRI, and at that point you have a non-fixable rotator cuff tear that could have been fixed 6 or 12 or 18 months prior, you've harmed yourself. You've harmed that patient's been harmed. They've missed an opportunity to have a normal shoulder, and that's a bad problem. So I think the treatment, the best place to get treatment for any condition relies on a good diagnosis right out of the box, whether that's a heart condition, problem with your liver, your stomach, your knee, your shoulder. What treatment's going to work and what treatment is best is driven by, first, the right diagnosis. And the best people to get the diagnosis of a shoulder problem typically are orthopedists or a well-educated family medicine doc, facile with diagnosing musculoskeletal problems like shoulder pain. So we're going to shift gears here a little bit and move away from issues related to rotator cuff and talk about other tissues in the shoulder, namely the cartilage. Cartilage is a tissue that coats the end of our bones. All of our bones, our finger bones, the ends of them have cartilage on them. The ends of our ball and socket have cartilage on them. Here, this is a picture of the upper end of the humerus. This is the bone down here. And this stuff up here that looks like an egg or a cue ball is the nice, smooth, white cartilage that coats the end of the bone. And it's that cartilage that permits nice, smooth, pain-free motion in our joints. And if you've had, when you look at the end of a chicken bone, it's coated with cartilage as well. It's very low friction when you move a cartilage on cartilage surface that's lubricated with normal joint fluid, 1,000 times less friction than bone rubbing on bone. It's painless when you have cartilage rubbing on cartilage. However, cartilage itself, if you compare it to other types of tissue in the body, is wimpy. It's pretty frail, and it oftentimes does not hold up to injury as well as other tissues such as bone. And so it can start to break down or wear out. And when that happens, the cartilage sort of fragments and floats away in little bits, which leaves a denuded bony surface. And this is the upper part of a humeral head that's been removed as part of a shoulder replacement surgery. And there's a little margin of cartilage out here that's badly worn, but this is exposed bone. That is, this used to be covered by cartilage like this, but over time in this particular patient, that cartilage wore away. And now they have arthritis, which is the condition, is what we call it when the cartilage wears away. Arthritis with an exclamation point, apparently. So the loss of cartilage results in bone rubbing on bone, which is much higher friction than cartilage rubbing on cartilage. As a secondary effect, you can develop bone spurs down here. These little extensions, your bone starts to grow a bit more. When you develop arthritis, the bone itself can erode. These processes can limit motion in the shoulder. It's not a nice, smooth ball anymore. It starts to become out of round. The bone on bone, the high friction generates inflammation, and that generates pain. So those patients who have shoulder arthritis often complain of pain in the shoulder, limited motion. When you get x-rays of these patients, they sort of look like this. You can tell the ball that used to sort of extend out here has sort of been flattened in this case. And the nice space that we typically see on an x-ray between the ball and the socket is gone. No separating the bone of the ball and the bone of the socket anymore. The space is essentially nil. Here's another x-ray showing the same thing, narrow joint space. The ball has been eroded out of round into a sort of a flatter faced ball, bone spurs extending down here. A very typical x-ray in somebody who has shoulder arthritis. Non-surgical treatments for arthritis are many. Activity restrictions, if you say, doc, it hurts when I do this, the doc, Weisenheimers that we are, will say, well, don't do that. That's okay for you to do with shoulder arthritis, to simply limit your activities such that they don't hurt you. Medications, things like Aleve, the other anti-inflammatories, if it's medically safe for you to take those. Tylenol is another class of medications that's different than anti-inflammatories, can be quite effective, especially when the arthritis is mild. Physical therapy is recommended by some docs for patients who have shoulder arthritis. I found the results of long-term physical therapy for shoulder arthritis patients to be not very satisfying from the patient's perspective. Cortisone injection or injection of other things tend to not be effective because in the end, the patient still has bone rubbing on bone. They still have arthritis. These things can help with the symptoms, but in the end are not curative. Because they don't eradicate the underlying condition, which is bone rubbing on bone. Usually at this point, we start we get questions more frequently now than a few years ago about stem cells, shown in these syringes here. It's been quite a topic of conversation on 60 Minutes. There's been some podcasts produced about stem cells, quite a lot of marketing. It is an experimental treatment. It is quite expensive. Talk a little bit about that. It is largely unregulated. Um, there is no proven benefit. There's no study showing that patients who have arthritis of their shoulder who get stem cell treatment are cured in any ways. A small percentage might feel better briefly, and a lot of the studies that exist are funded by the companies that make a great deal of money from selling and injecting these products into your body. So I'm quite skeptical about stem cells as a effective long-term treatment for a variety of reasons. For example, we don't know where they go when you inject stem cells in your shoulder. Do they adhere to the denuded bone, or are they absorbed by the joint lining and of no benefit whatsoever? Do they have some sort of anti-inflammatory component? What we know is they certainly don't regrow cartilage. If you inject these cells into your body, they don't naturally adhere to the denuded bone and form new cartilage magically. So we're hopeful that injection therapies such as stem cells will evolve to the point where we can do that and avoid surgery altogether for these patients with this bad, painful condition. But we're certainly not there yet. All right. So after non-surgical treatment has been exhausted, if the patient's still dissatisfied because their pain and motion are worsening or persisting and limiting them, they can't sleep, they can't function in their regular daily activities, then oftentimes the orthopedic surgeon will suggest as an option shoulder replacement surgery. And these are illustrations showing what a shoulder replacement consists of. Shoulder replacement consists of removal of the ball with a saw and then putting this new metal ball in place. And that metal ball rubs on a plastic socket. This not only is the ball resurfaced, but also the socket. The socket's resurfaced with a plastic component. So when that patient moves their shoulder now, they don't have bone rubbing on bone anymore. They have metal rubbing on plastic. And these materials naturally don't have any nerve endings, so it doesn't hurt. There's no bone grinding on bone anymore. If you were to take an x-ray of this patient's shoulder, would look like this, where here is the ball. The plastic doesn't show up very well in the x-ray, although they do put a radio opaque marker in the socket component. So when you get an x-ray, there is an indication that there is indeed a plastic line socket in there. This ball is fixed to the patient. Typically, it attaches to a titanium stem that goes down inside of the bone, believe it or not, and then the bone will grow onto this stem, and that will allow this ball to be fixed to the patient's bony anatomy. Patients are more likely to request this. It's never something that we tell a patient they must have. Patient usually asks us, "Hey, I'm tired. Can you please do? I'm tired of this pain. Can you please do the surgery?" There's certainly no rush to that. The surgery itself takes an hour or two. It requires an anesthetic, typically a general anesthetic. Again, it's effective because it eliminates bone-on-bone contact. Consists of resurfacing the ball and socket. These are other illustrations of different types of shoulder replacement. Both consist of a metal ball and a plastic socket. This is considered a standard, or what we call an anatomic shoulder replacement. And then there's a relatively new surgery called a reverse shoulder replacement, in which instead of putting the ball here on top of the humerus, you put it on the end of the socket. And instead of putting the socket here like you would in a regular shoulder replacement, the socket goes on top of the humerus. And I'll explain why one might best be served by a standard or anatomic shoulder replacement and why others might be best treated with a reverse shoulder replacement. But the outcomes are comparable, whether you need this or that. Usually patients are quite satisfied. In a standard or anatomic shoulder replacement, the ball is here. It's on a stem that goes down here. The plastic socket's on that side. And on the reverse, as I described, the ball is placed on the opposite side, as is the socket. The complication rates of a standard and reverse shoulder replacement are about the same, 1 to 5%, depending on the study that you read. However, the complications of the reverse tend to be more severe. That is, while they occur at the same rate, rates of complication of the two are roughly the same. If you look at the severity of the complications associated with a reverse shoulder replacement tend to be more difficult to solve and more severe. We tend to use a standard or anatomic shoulder replacement, essentially if the rotator cuff is intact. The muscles and tendons that you might recall us describing earlier in the talk, if those tissues are all intact at the time of the shoulder replacement and the patient just has arthritis with a normal cuff, those patients are best served with an anatomic or standard shoulder replacement. However, if the rotator cuff has bad tear, which is not unusual, then those patients are better served with a reverse shoulder replacement. Most patients, whether if they get the surgery that they want, whether that's a standard or reverse shoulder replacement, most of the patients are very happy with their outcome because their pain is gone. Look at how happy this guy is. They're mostly happy because the pain they had before their surgery is gone. Like most joint replacement surgeries, knee replacement surgery, hip replacement surgery. I've had hip replacement surgery myself. The main patients, when they come back in to see us after the surgery, we ask them, number one, are you happy? And if they usually say yes, and we say why, and they say because my pain is gone. I don't have that pain anymore. That pain was killing me. It was affecting my life, and now I don't have it anymore. I'm so glad I had the surgery done. The motion is painless. Usually with a shoulder replacement, the motion is nearly normal. So this guy's a good illustration. That's why I picked this picture. If this guy has a normal shoulder on his right that's never been affected by arthritis, never had a surgery, this is sort of the standard motion that we see in a shoulder replacement patient. For some reason, we just can't recreate the normal motion with the shoulder replacement surgery and parts for some reason. But still, these patients are quite happy because, again, their pain is now absent post-op. Complication rates are low. Recovery is typically 2 to 5 months in duration. The durability of these components is excellent to good. This is what we call a survival curve. And when we share information about shoulder replacements, one of the defining features is how long does this last the patient? If they have a shoulder replacement today at time 0, and we follow those patients for 10 years, what percentage of those shoulder replacements are still on the road? Like if you put 100 cars on the road today, like the old Chevy truck ads, what percentage of them are still on the road 10 years down the road? And this graph shows pretty typical for shoulder replacement. 90% are still functioning at 10 years, 80% at 20 years, and so on. So the durability of them is quite good. It's not perfect, like the brake pads on your car. They're not bomb. These shoulder replacement parts are not bomb-proof. They can loosen or have other problems requiring redo surgery. But in general, most of them outlive the patient. All right, so that's the discussion of shoulder arthritis, shoulder replacement. Ms. Joyce, any questions about that?
Margaret asked, can you explain about joint fluid leakage that has calcified?
Yes, you can get a condition called calcific tendonitis. That's not common these days, in which I'm not sure it's related to joint fluid leakage, but you can get calcium deposits in and around your rotator cuff, and that can cause tendonitis. The treatment for that is often non-surgical injections, therapy, that sort of thing. But if it's really problematic and the pain persists, then you can excise those calcifications and repair the diseased tendon around it. Other calcifications that are not related to joint fluid leakage, things like the bone spurs we showed on those x-rays, those are typically removed at the time of surgery. If you just remove those alone arthroscopically, the results of that are not great because those patients still have bone rubbing on bone. Does that answer the question, Margaret?
Yes, thank you. I just had a question as far as the calcifications themselves, because I was told that they could be removed, the pieces of the calcification can be removed surgically, but I don't think the outcome is great. The percentage that they can take out doesn't always amount to the 100% removal. So I wondered what your experience is with removing those calcifications.
If it's calcifications embedded in the tendon, I would say the results of that are quite good. It'd be equivalent essentially to a rotator cuff repair patient. The calcification is embedded into the tendon, and so you have to shell it out with a little scalpel, and you cut it out. Now you have a little defect where that calcification used to be. There's a little void there, and if you repair the tendon over the top of that typically the patients do quite well and you can remove all the problematic calcifications. Now, that's not a common condition. It used to be more common in the 60s and 70s. They think before standard water processing plants in the US, for whatever reason, there was more calcium in well water, for example, that would accrete in patients' rotator cuff tissues. We don't see that as much anymore. So the more common calcifications are those that occur in the form of bone spurs around the shoulder. Those can be, it can be difficult to remove all of those, to be sure. But those tend to occur in patients who have arthritis. So that begs the question, well, what is causing the pain in my shoulder? Is it these bone spurs? Is it these calcifications? Typically, it's not. Typically, it's the greater problem of bone rubbing on bone, that bone rubbing on the bony, eburnated bone of the ball and rubbing on the denuded bone of the socket. The bone spurs are around there. Certainly, they're not normal, but the bone spurs are typically not causing the pain. So even if you were to remove all of those calcifications in that condition, those patients often still have arthritis pain because they still have bone ball rubbing on the bony socket.
I see. Thank you.
Okay.
Thank you.
Another question I have, Dr. Lawton, is does collagen supplement help with shoulder arthritis?
Glucosamine chondroitin is a building block of cartilage. You can buy it over the counter at Walgreens. The results of ingesting that on arthritis are, it works, seems to be as effective, a little bit more effective than placebo in terms of reducing shoulder pain from arthritis, or hip pain for hip arthritis. I took it before my hip replacement, didn't seem to help me very much at all. But it's relatively cheap, it's super safe. Patients who are interested in trying it, we encourage them to try it. There doesn't seem to be much downside. So, but that's different than saying, if you take it, it will rebuild your cartilage. Those comments are close. It's a building block of cartilage. And if you take it, will it regrow your cartilage? Are there good studies showing that? Not really, because as soon as you take it, first thing that happens when it gets in your stomach is it's broken down and digested by your body's enzymes. And when it's absorbed in your bloodstream, it doesn't necessarily know where to go. And its ability to sort of find its way to your arthritic joint and sort of hook up and get on the bony surfaces and lay down a new sheath of healthy cartilage is quite poor. So that's why in the studies that look at the results of taking cartilage building blocks like glucosamine chondroitin don't show much long-term improvement or curative effect in patients who have bad arthritis of the shoulder, knee, or hip.
Another question from Lina is, can plastic cuffs be used in other anatomic joints? And what is the downside of using plastic cuffs?
Yeah, plastic is part of most joint replacements. So if you've had a knee replacement, ankle, hip, chances are probably 9 in 10 that the socket or one part of the replaced joint is plastic, and the other part is usually cobalt chrome or ceramic. And it's that cobalt chrome on plastic, or ceramic on ceramic, or ceramic on plastic articulation that is nice and smooth and very low friction. So yes, it is used commonly in other joint replacement locations, other anatomic locations. Now we'll talk a little bit about sports-related shoulder pain, or probably more broadly, activity-related shoulder pain. You don't have to be an athlete to have activity-related shoulder pain, but we do see it a lot in athletes. This picture is a patient of mine on a national volleyball team. She's from Southern Colorado, and she had this problem that we're going to be talking about. Our understanding of shoulder pain has really evolved quite significantly over the last 15 to 20 years. Prior to that, a lot of shoulder pain in the throwing athlete was misdiagnosed, and the treatments were largely ineffective. And so it's been nice to sort of live through that as a practitioner, to learn from our colleagues, hey, these problems that we used to deal with in the shoulder and we used to diagnose as A, B, and C, guess what? We were wrong about that. Instead of A, B, and C, it's now D, E, and F. therefore, the treatments of these things, it makes sense that the things that we used to treat the shoulder for were ineffective. And so now here are these newer treatments. And boy, we've certainly been glad to add those arrows to our quiver and improve our ability to understand these patients' pain and help them get back to activity more effectively. The lion's share of problems in the overhead athlete are related to the labrum and the biceps, and I'll explain what those structures are. But first, a little ethological discussion, that is, our shoulders, our arms are designed to be used mostly out in front of us. If you can think of us sort of evolving from quadrupeds, we're down on all fours, or primates where we're using our arms up like this. This is how our shoulders are designed to be used, and all the anatomy and all the tissues in and around the shoulder work quite well as long as we're like this. But when you get the arm back in this position, or in the position shown in this picture here, all of a sudden that puts the arm into a position that maybe it wasn't designed to function in, and that puts unusual stresses on the tissues that were not designed to do some of these things. So things like baseball, swimming, a volleyball, in which the arm is put way back like this and twisted, put these unusual forces on the upper part of the labrum and the biceps. So this is looking at a shoulder socket from the side. If you were to look at me from the side and remove my arm completely, you'd be staring right at my shoulder blade, right at the socket. Right here, here's the cartilage of the socket. It has this sort of pear shape. And then going all the way around that, completely encircling it, is this sort of leathery ligament called the labrum. And in patients who are overhead athletes, volleyball, baseball players, when you twist your shoulder over and over and over again, thousands of times, you can develop a little tear right here where the labrum attaches to the bone. That is, the labrum attaches to the bone all the way around the socket, including up here. And this illustration shows a tear of the labrum right here. The biceps muscle, your biceps muscle here, becomes a tendon. And that tendon right about here becomes a tendon, comes up, goes deep inside the shoulder, and attaches oddly to the labrum. That is, this tendon, for whatever reason, doesn't go from this bone down to your elbow. It attaches to the labrum, which is very unusual for a tendon not to attach to the bone on its upper end. But at any rate, we think that contributes to this as well, and we'll explain why. Here's looking at a right shoulder from the front, where this is the ball, this is the socket. Here's the labrum going around the shoulder, and here it is up on top. And here is a tear. This part of the labrum should be attached to the bone over here and is torn, and this is the biceps attaching to the upper labrum. And the reason we think that occurs in overhead athletes is here is the shoulder in relatively normal position, where here's the socket, here's the labrum, here's the biceps attaching to that. But when we put the shoulder back in this position like this patient here, what happens is the labrum twists, and that puts abnormal mechanics on the upper labrum, pulls it away from the bone. Here's an arthroscopic view. This is a picture taken during an arthroscopic surgery where this is the socket or the glenoid, the upper part of it here. This part of the labrum is attached relatively normally, but this probe, the surgeon has the probe in here. And so that we call that a slap tear. That stands for superior labrum or upper labrum, anterior to posterior. That's just a fancy term that means you have a tear of the upper part of your labrum where the biceps attaches to it. The pain, these patients who have this problem usually have pain at the apex of their throw. That is, when their arm's back in this position, they start to accelerate through either their swimming stroke, their tennis stroke, their volleyball stroke, their pitching, throwing cycle. The treatment for it is often non-surgical initially. Let's rest this patient. Maybe if the tear is small, we can get it to heal on its own. We're going to restrict them. We're going to hold them out of participation for a while. We're going to try to medicate them with the usual medicines, Tylenol, anti-inflammatories. Physical therapy can be pursued as well. If there is a significant tear like this and that patient wants to return to throwing, often non-surgical treatment does not cause this tear to heal. And these symptoms will persist in spite of the best non-surgical treatment attempts. The surgical treatment consists of trimming up this tear. You essentially take out this part of the labrum and take out this part of the biceps and tack the remaining part of the biceps down to the bone, as is illustrated here. You can use a plastic bio-inert screw to tack the biceps down. This part of the biceps is therefore taken out, and this tear is trimmed up such that when the patient puts their arm back in that position, the tissue doesn't hurt anymore. The biceps is not pulling on it and torsing it anymore. The success rate for the surgery is extremely high. These are among my most satisfied patients. Recovery is 3 to 6 months, and has really been a great breakthrough for us dealing with athletes in sports medicine, especially in overhead throwing athletes. So that's the end of the talk on sports-related overhead throwing athletic injuries. Joyce, any questions about that?
Yeah, you have a couple in the chat. Daryl Schaefer asked, thanks for doing this presentation. And would you care to rate the various pull-ups? Pull-up, chin-up, hands up, hands facing pull-up regarding strain on shoulder, and if one is more effective than the other for shoulder strengthening?
I would say there's not much, unfortunately, not much data for us to hang our hat on there. So I would defer to each individual athlete. As somebody who used to do pull-ups myself, I found palm forward to be easier for me to do than palm away. I don't think there's any data to suggest that one is better at strengthening the shoulder or latissimus or biceps than another. So I would say that's dealer's choice.
Jim Ferris asks, do diagnostic tools clearly differentiate between types of inflammation, bursitis, capsulitis, arthritis, and minor to major tears? And is the risk of misdiagnosis low?
Yeah, I think getting the right diagnosis around the shoulder can be quite tricky. So I think an MRI can delineate between those entities. For example, it will show if you have a rotator cuff tear. Especially if it's a significant tear all the way through one or more tendons. That will show up on an MRI quite easily. Bad arthritis as a cause of inflammation will show up on an MRI. Other more subtle causes of inflammation or conditions associated with inflammation, frozen shoulder specifically, that can be very hard to pick up on an MRI. You can have an MRI that looks pretty normal and still have a bad case of frozen shoulder. If you have a really raging case of frozen shoulder and you have a good MRI and you have a very good good radiologist, that's the other part of the equation we haven't talked much about, who's used to seeing what a frozen shoulder looks like on MRI, they will rarely be able to suggest a frozen shoulder in this patient. Subacromial bursitis, a bursa that's inflamed over the top of the cuff, if you have a really bad case of that, that often will show up on an MRI as well. So I think the short answer is usually the MRI can be helpful in reaching the right diagnosis, but it's not a perfect tool. It's just a tool. And we have patients who've had shoulder MRIs, get the wrong diagnosis, and go off on a treatment path that's not effective for them, and they come back understandably frustrated until the right diagnosis is arrived at. Okay, so we just go to this is our final slide. The bottom line with shoulder is it's got a lot of parts. Just like this beautiful old Cadillac, it's got a lot of parts, and there are a lot of moving elements that any one of which or more than one can fail. And if something in the shoulder gets torn or wears out, it's likely going to generate pain. If it gets inflamed, it's likely going to generate pain. And so just like finding out why the caddy isn't running well, you got to find out why your shoulder isn't running well. You need a good diagnosis. But the good news is most shoulder problems are identifiable, diagnosable, and fixable. Once you have the right diagnosis, then we typically know, hey, for this diagnosis, these are the treatments that typically work. These are the things that may or may not work, but there's not much downside to us trying them. These are the ways we can get more data or more information to make sure we are indeed working on the right diagnosis. And these are the treatments that tend to work and the risks and benefits associated with them. And typically, most shoulder patients are quite happy, assuming they've had the right diagnosis and treatment. That's it. That's the bottom line.
Great. Thank you very much. This has been a really comprehensive presentation. We have a question from Hester Honda. Hester, you want to unmute yourself and ask your question?
Yeah, thank you, Dr. Lawton. Would you address the issue of primarily women who carry these heavy, heavy purses on the same shoulder all the time for 50 years?
Mm-hmm.
And should we be balancing the load somehow?
Well, first of all, I don't like to be struck by their purses when they swing them at me. So that's number one. That's the most important thing right there. No, I mean, in all seriousness, I don't know. I think that might fall under the category of repetitive lifting. You know, essentially, those are like women who carry purses and lift them repetitively with one arm are essentially like the picture we saw earlier in the talk of that person stocking shelves. Now, if you're carrying it on a strap and the strap is over your shoulder, I don't think there's any data to suggest that those patients are at any significant risk for damaging the tissues about the shoulder proper. I would say if you have a heavy purse and you carry it and it's not hurting your shoulder, to knock yourself out, I think it's fine for you to carry on.
Hey, thank you.
You're welcome.
Oh, okay. One more question from the chat from Daryl again. Any data or opinion on best choice between over-the-counter anti-inflammatory meds?
No, it's funny. It's a great question, and we find that some patients really respond well to ibuprofen, which is Advil or Motrin. Those are all three the same things. Other patients seem to respond really well to Aleve. Some patients respond to one and not the other. Other patients respond well to both. And it's hard for us to figure out when face-to-face with the patient which of those categories a given patient is going to fall into. So we think it's fair to try both, especially if the is not being very effective. Now, the trade-off, Aleve tends to last longer than ibuprofen. So patients are having pain more throughout the day, a longer-term pain, or throughout the night. Aleve makes a little more sense, provided that its efficacy is equal. That is, if the patient takes Aleve and they take ibuprofen, they're equally effective. They have pain through the day. That would sort of nudge us maybe to recommend that patient take Aleve. But we've had some patients take Aleve and they say, it doesn't do anything for me. Advil works very well for, or aspirin, which is another anti-inflammatory medicine. That works great for me. These other ones don't work so well. So it's a bit of trial and error, and it goes patient by patient. And I guess that would be the best way for me to characterize that. Otherwise, there's no real difference.
Okay, any other questions? Well, thank you very much. I'll put up in the reactions button here. I'll have some applause for you.
Oh, my goodness.
Okay.
Thank you very much.
No, this is really great. And this is, I guess, one of the nice things about having doing this on Zoom. We can get people from out of town to do these presentations, and it was great. We really compliment you on your presentation. He did present a lot of information today, very useful information. So it'd be helpful
It
for
was
us.
overwhelming, but thank you very much. I appreciate it.
This was great. Thank you so much. So I'm going to turn this over to Russ now, who would like to say a few things about upcoming programs. Russ, you want to?
In terms of future classes coming up next week or open to the public, we have on Tuesday, February 9th from 1:45 to 3:45, the history of rock and roll. And next week, they're going to be presenting the Michael Jackson story. On Wednesday next week, we have another medical presentation, and it's at 9 a.m., and it's how to get the most out of your doctor visit. Next Saturday, we won't have a class here in Transitions to Retirement. And 2 weeks from today, we have a class on retiree health, social trends, and technology use. Our presenter there is one of our top presenters we've had at OLLI over the years, Dr. Laura Zettel-Watson. She's been presenting at OLLI for about 12 years now, and she's done quite a few for us. And this particular one, she's going to focus on retirees, aging, health, in social network trends, the importance of social relationships, social support, and technology utilized by retirees will be covered. So I think that'll be a very excellent presentation. And I think that's it in terms of future classes.
Hey, thank you, everybody. And Dr. Lawton, I think your mother is in the audience.
Did I not make my bed?
Okay, so goodbye, everybody. Again, thank you so much. It was great to meet you, and we hope we'll see you in person someday, Dr. Lawton.
Thank you very much. I appreciate
Thank
it.
you.
Very nice. Thank you.
Take care.